Hi, everybody. You are listening to ToRAISE Questions Doula podcast. I'm Melanie Russell, the Executive Director of ToLabor, which is an international birth doula training and certifying organization. I'm really glad you're here. All right, welcome back. You're listening to ToRAISE Questions Doula podcast. I am here with Sarah Cole. Welcome back, Sarah.
It's good to be back. Thanks for having me.
Always. I love these little, unfortunately, I feel like we're talking about some kind of doula gripes when you come in.
I'm here for the complaining.
Next time we'll have something, when everything goes right. That'll be the title of the next one when you come on. Give us a background. Who are you? What's your intro?
Well, I am Sarah Cole. I'm a certified birth doula. I work alongside you in Richmond, Virginia, and I'm also a certified breastfeeding specialist. I teach classes, the childbirth education classes at A Brighter Birth, the education coordinator there, and then I also teach a breastfeeding class as well, which I do via Zoom, which is really nice because pregnant people plus me are tired in the evening, so it's nice to have everybody just kind of progresses closer to their bed as the class goes on. Like we take a little break and then everybody's a little closer to bed. And then by 9 o'clock, everybody's cozy.
The eye masks are on.
Exactly. We talk about wax poetic about boobs until everybody falls asleep.
Perfect.
Other than that, I am a parent of 4 kids and just trying to juggle all the things.
All the things.
So, yeah.
And you also recently started teaching lactation for ToLabor in our combo training.
Yes, which is super exciting and a really fun, it just feels very full circle since I was trained by ToLabor, and it's really nice to be able to take some things that I've learned over the years and be able to create a training that isn't just about the technical stuff of breastfeeding, which is important, but also some just little tricks that I've learned along the way that have been really helpful for me. So that's been really fun. I love being able to doula doulas a little bit.
Yes, and we love that you do that. And I think we are also going to have you do a mini workshop here coming up soon. So look out for that too. We're going to have some Zoom continuing ed mini workshops this year with Sarah Cole leading that off sometime in early 2026.
Super excited about that.
Yep. Mm-hmm. And then our next combo doula training will be again in September next fall. So keep your eyes out for more info on that. And that'll be that retreat style. So
yes,
I'll be cooking again. It'll be lovely.
It's really good food. So I'll be there for the food and also to teach some. It'll be great.
Yeah. All right. So fresh out of a training over the weekend, and we're always looking for what we want to bring to you all on the podcast, and it usually is correlating directly with what's happening in real time in our lives. What's a birth we've recently had or a topic we're talking about, something in the news, something that's relevant. And what the theme that kept coming up over the weekend in the training was how to navigate challenging situations with providers, staff, when you come up against something in a birth where the policy is different than what you're being told, or even when evidence shows that it is different than what you are being encouraged to do, or, I don't like this word, but allowed to do with your client. And so how does a doula navigate that with professionalism, respect, and kindness? And how do we actually get what we want out of it?
Right. Because being combative sometimes it works, and a lot of times it doesn't.
Most times it doesn't.
A lot of times it might, you might get something in the moment, but not necessarily build those relationships that allow you to grow and get even maybe more or make changes.
Right. And I think you and I both have walked through our careers with the same philosophy of taking the high road. When there's cattiness or competitiveness or anything sort of negative or icky feeling in the job, we go high and we just put our head down and do the work, right? And try not to pay attention to the stuff that doesn't feel good.
I put a lot of effort
in avoiding. It's not easy.
I put a lot of effort in avoiding that type of thing because I generally, I want to be a person, I want to come across as a person who does their work with integrity.
Yes.
And I want the people who are working around me to feel like this is a person who does their work with integrity.
Mm-hmm.
And sometimes that also means just staying out of stuff, staying out of stuff with the hospital, staying out of stuff, in the community in terms of just being like, well, I'm going to do my work and I'm going to do my work as well as I can.
Right.
Advocacy is different. We can
Yes.
talk about advocacy. And I think that's important for this discussion. But in terms of, just trying to make sure that I'm representing myself well when I walk in.
Yeah. And, one of our 5 essential components in the training is collaboration. And so that means that we are actively putting that effort into collaborating with the team. And that means, though, that every role in that room deserves respect.
Mm-hmm.
And unfortunately, and I think this happens in a lot of different workplaces, different careers, there is a hierarchy. And with that hierarchy, then that lends to ego. If you all haven't listened to the podcast, I think I brought this up on one of our early comeback podcasts, but the serial podcast, The Retrievals, season 2, where they talk about the pain relief in C-sections. A lot of what they are discussing as a challenge is dealing with different providers and anesthesiologists' egos. And so even just changing the verbiage around pain relief has helped people not take things personally.
Mm-hmm.
So, when I walk into a room with a client, I am always trying to immediately establish a good rapport with everybody in that room, show my respect for everybody's role. But that also means that my role also deserves respect. We try to stay in our lane, but sometimes we come up against a recommendation or a denial of doing something that we know would benefit our client, or we know maybe we did the same thing last week in the same hospital, in the same room,
very same room
with a different provider or a different nurse, and now we're being told differently.
I think a part of that too, this kind of coming in these different levels and coming in with, some respect for everybody that you're working with also is that I think coming into play also is a little bit of a lack of understanding of what our role is sometimes.
Yes.
And we also have to acknowledge that nurse may have just come from another room where something really hard is happening. That provider may have seen something and be particularly afraid of a certain thing.
Mm-hmm.
And also they may not always understand the capability of a doula, what we know and what we don't know. And so I think sometimes coming in with a professional attitude, coming in with a collaborative spirit, coming in with respect for everybody's roles can kind of help establish a place where we can come to an understanding of what a doula's role is in the room.
Absolutely.
And so I think that right off the bat, is kind of that first contact is sort of where we start that.
Sure. So, in the training, we also talk about how these are systems that we are seeking to change. We talk a lot about how we're educating the doulas on the midwifery model of care versus the technomedical model of care, and just the differences between those, and how it's systems that we are seeking to change or to, just like you said, enlighten those systems with really what our role is and how even the systems can benefit from a doula being in that place. Saying that, though, to what you just said, that provider, that nurse could have an experience in their life, and that provider could be a midwife, it could be an OB, could have had an experience in their life, in their career, that has shaped their construct of birth, which has then just made a decision in their practice that they won't do that.
Right.
That's not how they practice anymore. Maybe they had a bad outcome years ago when one, maybe someone's water broke and they got in the tub and then there was a terrible infection. And then now they're saying, okay, no, never again. When membranes are ruptured, will my patient be in a tub? And we know that's ridiculous.
Right. Right.
Right? Like that is probably not where that infection came from in the first place. But we then are up against one provider within that system, which is tough. So as a doula, have you been in this position before?
Many times. Many times.
And let's walk through how would you conduct yourself in that sort of scenario of being told something that you just know is not true? Or your client being told something that you know is not true.
Yeah. Obviously every scenario has a degree of nuance to it, right? It depends on your client. It depends on your client's goals. It depends on how well you know people at that hospital. There's obviously a lot of nuance to all of it. So I think that there's a lot of answers to that question. If the provider is still in the room and we're having this conversation, I love to ask more questions. That is one of the first ways in which I might also sort of indicate to my client that there are more things that we could be looking at here. So the BRAIN acronym, which we teach in class, right? For the benefits, the risks, the alternatives. That alternatives is one that I really like to ask about. And I might ask my client, hey, client, do you have any additional questions about what this might entail, or whether or not this includes, if you'll still be able to get out of the bed if we go this route, or, some things that I know that were really important to you.
Right.
Or I might just ask the question, hey, if we did this, would this change XYZ or whatever? So
are you saying doulas are allowed to ask the providers questions?
I like to ask the providers questions.
Yeah.
I think that, first of all, I always learn something when I ask providers questions. So it doesn't necessarily have to be a leading thing. It's just like, hey, I would love to know more about that. Tell me if I don't know about something. I learn something at every birth I'm at.
Absolutely.
And sometimes I learn from the providers, and sometimes I learn from my clients, and sometimes I learn from the nurse, and sometimes just the experience itself. So if I have the opportunity to learn more about something, then I would love to ask that. Now, if I know it's not necessarily a policy thing, I might ask, did the policy change on this? Because I remember last week we did something different, and I just would love to know if the policy has changed, because that helps me, as we navigate things further.
Sure. Okay. And that's something that we talked a lot about in the training. What is the doula's role in that room? Are we speaking up? Are we interjecting? Are we, we're bringing options into the room. That's one of our biggest jobs, right? But I think a lot of newer doulas feel a little afraid to really use their voice, especially when the provider is having a conversation with the client. And then maybe once the provider leaves, then the doula might step in and say, well, okay, let's talk about XYZ. And they said this, but really this might be another option for you. So I do want to make sure that doulas understand your voices can be used.
Absolutely.
In that room.
And I think that also when we wait until the provider's out of the room, it makes it seem like we're trying to undermine the provider.
Exactly.
And now I have done that. I've been like, okay, because it was very clear that this provider didn't want to talk to me or answer my questions. I've had providers who will completely ignore me, or I'll say something and they'll look at their patient, my client, and say something small and leave. Also, if I'm not sure how my client feels about something, I may wait until the provider leaves and say, how are you feeling about that?
Yes. Number one question. How are you feeling about
what
this?
What do you think about that? And I think that's where the distinction lies. I can bring more options into the room. I can ask questions and see where, what other options are. I can make sure that whatever information that my client has is as thorough as I can get out of that conversation in the moment, but I don't make decisions for my client and I don't make judgments on it.
Exactly.
So this happens with things like inductions all the time, for example. So if a client comes to me and like, okay, we scheduled my induction for Tuesday. This is what we're going to do. It's not my job to say, well, inductions are really awful and here's why. And you wanted to do this way and now we're not doing that. But if she's feeling really positive about that induction, if that is what's giving her peace and bringing her peace, then my only job is to make sure that she has realistic expectations for what that induction looks like. So she's not disappointed by that experience and feels fully empowered going forward with the plans that she made with her provider. I don't have an agenda. My job isn't to have an agenda aside from, my client having a positive, empowered experience.
Right. Supporting your client. And sometimes that support shifts multiple different directions during that one labor.
Yeah.
Because the labor will shift and then decisions will shift and their desires will change from what they may have told you on their couch at 37 weeks. And then it might feel a little bit different at 6 centimeters dilated going into hour 36 of labor.
Yeah.
And that's okay.
Exactly. And sometimes they will want to make a decision that isn't evidence-based.
Yes.
And that is within their right.
Yes. Okay. So when something comes up that you're coming up against with a client that the provider, the hospital system, the nurse, someone in that hierarchy, quote unquote, above you in that room, is saying something different than what is true. The first question still has to be to the client, how are you feeling about this? Because if the client is feeling great about whatever.
Yeah, that feels good. I like that plan.
That sounds,
I'm in.
Yeah,
that's good.
I'm in.
I think that's great.
Perfect. Okay. And then where do you put that stuff? Then you're like, oh, this is so frustrating. She wasn't even given this option. I know we could have done 4 different things.
Yeah.
Where does that energy go?
Now, sometimes based on how well I know them, I might say, look, my job as your doula is just to make sure you know that you have options. Here are a couple of options that you can. Well, and also to make it clear, like, this isn't a judgment thing. This is what my role is. Sometimes I might even say, also depending on how well I know this client, would more options be overwhelming for you right now? Like, do we just want to go with what we've got, or do you want a few more options and things that we can discuss? Yeah. Some people get really overwhelmed by lots of options. And so, and also like, there's no need to throw out options that aren't going to be available at this particular, we've made the decisions that we've made. We're in the birth location. We have the provider. Those are decisions that we've made. Sure, you can fire someone in a specific circumstance, but so working within the parameters, do you want to know, any other options, or you feel good sticking with where we're going?
Because then I love that, because what happens if you don't ask those questions and you just sort of steamroll the client into, as soon as that door closes and you're like,
I don't like that.
She's wrong. This is actually what's true. And we could do this and this and this, and they're not letting you do what you want. And I'm so frustrated. If the client was fine with that plan, who becomes the bad guy?
Yeah, you do. And not only do you,
and then she loses trust in you.
And you are doing exactly what the providers, this is, you are just as bad as the provider in that case.
Right.
Like, our job isn't to steer that. And also now her experience is filled with doubt.
Yes.
And like, well, did I make a wrong decision? Should I not have done that? Who do I listen to? Now there's loyalty issues. Do I stay with my provider that I've been with since I was 16 years old and I started birth control? This is that. Or do I listen to this new doula who, I trust and have a good relationship with, maybe admire, maybe, feel really confident about. And now I have now I'm divided into two.
Right.
And that's a really hard position to put your client in. It's also centering yourself in a way that's completely, again, who are we serving here?
Exactly. Then you're bringing your story into this, your feelings into it.
Right.
One of the examples we give in the very first night of the training, how to advocate for somebody without speaking for them, is really a facilitation of a conversation. The example that we give is you're with a client, you've been laboring for a long time, they've been doing great, they've gotten to the pushing phase, they're pushing's taking a little bit of time, which is totally normal, and you see the provider reach down and grab a pair of scissors. And you see that they have the pair of scissors in their hand, and you also notice they are not talking to their patient about it at all. And so in the training, I say, you may want to lay your entire body over your client and say, no, don't do it, because we're thinking episiotomy, right? We're thinking this provider is thinking about cutting an episiotomy, making more space for baby, and speeding up this pushing process. But we can't do that. So we have 3 options here. 1, we can look to our client and we can say, it appears that Dr. So-and-so might be thinking about performing an episiotomy. Do you have questions about this? Right? So then we've opened up the door to having a conversation. We've sort of outed the provider about, what they're doing, which they might not be happy about, but they're the ones that picked up those scissors. Or option 2 is we can look to the provider and we can say, could you explain to her what you're thinking about right now, what you're thinking about doing? Option 3 is we do nothing. We bite our tongue. Maybe not in this specific example.
Yeah, maybe not when it comes to people's
Not
bottoms.
when it comes to people's perineums being cut. But in a different example in a birth, maybe we are being triggered by something that we wouldn't choose in our own birth experience or in our own lives, but we're not checking in with our client first.
Right.
And so if our client is choosing something that makes us feel a certain type of way, that's work we need to do as doulas.
Yes. Yeah, absolutely. I think it is important too to know what some of those things might be for you. If you have, I feel like every doula has a little thing, they've all got their little thing that they're like, I can't stand X, right?
Yeah.
And and it can vary widely in my conversations with doulas on what that thing might be. I happen to know the evidence on this thing really well, and it drives me nuts when people do or do not do that thing.
Right.
And that's fine. We can have those feelings about that.
So one of my things that I can't stand is when we're pushing and the provider or the nurse starts counting.
Yeah.
And they're like, okay, hold your breath and we're going to do 1, 2, 3, 4, and, getting to 10 and really forcing that, forcing your client to hold their breath for those 10 seconds or however long they're counting for. And I know that's my thing. And so what I have done, what I've learned to do is I say to my client, is that helpful? Is that counting helpful to you? And when they say, yeah, it's really helpful, I'm like, okay.
I guess I'll be counting along with the rest of them.
1, 2, but that's just one example of it's not my birth.
Yeah.
It's not my birth.
And helpful is the point.
Yeah.
Right? So if it's helping you, great. It's not one I'm a fan of either. And so that's when sometimes I'll say either is it helpful or you can breathe when you need to breathe. Right. You need oxygen. You can breathe when you need to breathe.
Yep. Listen to your body.
Exactly. Yeah. Go as long as you can.
Yeah.
But yeah. And sometimes too, I notice that it's a lot of times when I have conversations, and I guess we can get into this a little bit too, I'll have a conversation. So what do we do with these feelings, right?
Yeah.
Also, say client is fine. They're happy with that. But we have we have some questions.
Mhm.
That's when a hallway conversation is really nice to have.
Love a hallway conversation. Yeah.
And like, this is again where establishing those relationships can be really helpful. It doesn't necessarily mean though that like you and I have been doing this for a while, you much longer than me. Like we know a lot of people. So when we go into the hospital, it's like, hey, like good to see you again.
Mhm.
But as a newer doula, you might not know anyone in that hospital. But out at the nurse's station, you can grab your nurse in the hallway, you can whatever and be like, hey, could you tell me more about the way this works here
But that's how you get to know people.
Exactly.
We know people. I have nurses' phone numbers in my phone and midwives' numbers and OB numbers in my phone because I had those hallway conversations.
Exactly.
Because I was direct about what I was experiencing in that room and the questions I had about it, and pulling people aside even when it is in an uncomfortable situation and just leveling the playing field, saying, do you mind if I just grabbed you for a second? I just have some questions about what went down. Again, leading with, and I love how when you are, showing an example of talking to a provider, I'm showing an example, our voice completely changes.
Yeah. Mm-hmm.
Right? Like we have to show up with that respect, that professionalism, really come to them curious.
Yeah.
Coming to them curious about how we could do our job better, how we could make this relationship a little more efficient together. Yeah. So there are those nuances you were talking about.
Yeah.
So those hallway conversations can be really helpful. And even if that hallway conversation leaves you feeling like, okay, well, maybe that didn't go as well as I wanted it to go.
Wasn't what I was hoping to get out of that.
That was a step.
Yeah.
In that direction. So then maybe the next time you work with that provider or that nurse and you show up again in that same way and you again meet them with kindness, respect, professionalism, kill them with kindness, you know?
And a little ego stroking doesn't hurt. I'm sorry.
Ego stroking does not hurt.
You gotta do it. You gotta do it.
Yeah.
Also, we can't, without curiosity, we're not going to be able to solve that problem. So another question I like to ask is there a hospital policy around XYZ? Because I feel like there's, I noticed one thing happened last week and then this happened this week. And I just feel like, is there a policy around this that I can speak to when I'm in the room, or that, is there any way? And sometimes they'll be really great with that information. Like, yeah, there is, and this is what it says. Or sometimes there isn't one, but it depends on who you're working with.
Well, how about when you get the answer, well, it's my policy. I've gotten that before.
It's my policy.
It's my policy.
So I can expect that when my clients are working with you, that's going to be the policy that they're going to be working with. But if they're working with someone else, it might change. Okay, well, that's great to know.
Great answer.
Yeah. Well, good. Great. Yeah. Now I'll just know that if my client's working with you, that I will let them know that that's one of the policies that to expect that. And then the expectations are where that they, where they need to be. And, thank you for clearing that up for me.
Yeah.
Yeah.
Love that. What happens when something is different than what you know, even during the prenatal experience? So, for example, I had someone recently reach out, having been sort of encouraged to have a late term ultrasound, 36 weeks. And, people love an ultrasound.
Yeah.
It's nice to see the baby, it's just a nice check-in. But we as doulas also know that there can be information gathered from those ultrasounds that might not be accurate.
Right.
That could sway someone into making decisions that they might not need to make. Right. So this client was told that they had an AFI, an amniotic fluid index level of 7 at this 36-week visit. Now we know that within normal range, a normal range of amniotic fluid level is anywhere from 5 to 25 centimeters. And so 7 sounds normal to me.
Yeah.
Right. So, but she was told that was low and she was told that now she would need an ultrasound every week. And if it gets to 5, then she needs to have an induction right away, that it's already low, and then 5 would be really dangerous. And so she would need to bring all of her bags to the next ultrasound just in case she needs to be induced.
Just immediately, without delay. That's not at all stressful.
Without delay. And also, she wasn't necessarily counseled on how her fluid intake would directly impact that amniotic fluid level. So she was left feeling like her body was doing something wrong. She was left with a lot of fear. And now she's gearing up for a 37-week induction, because that's what she feels like the provider assumed would happen.
And I feel like when things like that happen prenatally, people kind of wrap around this idea of being high risk. And I hear that a lot. Well, I'm high risk because, I'm high risk because this and that.
Because I'm 35.
Because I'm 35. Because I turned 35 yesterday. The day before I wasn't high risk, but today I am. Yes. And, or I'm high risk because, I have a client who is getting biweekly ultrasounds because of her BMI, which I have not run into before.
Ever before.
And so...
Or IVF.
I'm high risk because this, that. So one thing that I don't mind pointing out from time to time is say, oh, that's really interesting that they're doing that because I haven't run into that before.
Yeah.
And then I like to remind people that providers are humans.
Yeah.
Every provider operates a little differently. And it sounds like this provider is a little bit uncomfortable with fluid levels, for whatever reason or whatever.
Yep.
And then I like to arm them with questions. Here's some questions you can ask at your next prep. Why don't you ask them, how accurate are these measurements? How often do they change? What types of things influence? Is there anything I can do? Is there any place that I can get some research that tells me about fluid levels?
Right.
So if I can arm them with questions at their appointment. But again, we start with, how do you feel about getting all those?
How do you feel about this? Right. And so when I asked that question, how do you feel about this? That's when the fear came through.
Yeah.
The fear, the worry that her body wasn't doing what it was supposed to do. And luckily, I have a good rapport with another provider in that same practice. And so I was able to reach out to that other provider and say, hi, I have a couple questions for you. I have a client in your practice. This is what has happened. Would you explain to me what is this protocol for you all to do a 36-week ultrasound? Growth looks good. There was nothing leading them to believe that anything was off in this pregnancy to do the ultrasound. Is that protocol? And then is it protocol with a reading of 7 at 36 weeks to continue on this path and really induce at 5? And she said, no, it's not. That one provider tends to be a little more medical. And I think her exact words were, pretty trigger happy with recommendations, medical recommendations. And so then that is, okay, thank you for that information. But why do we have this practice with so many differing philosophies? It's a small practice. We, love working with them. But it really makes it so hard for the doula to recommend a practice as a whole, but then say,
but not that provider.
But this one provider might be saying this and this, but, make sure you don't schedule any prenatal appointments with them. It's so tough.
It is really tough. How would you have gotten that information, or how would you have approached it if you didn't have that provider's contact information, like a different provider? Like, what do you think you might have told? This way you had a little inside loop, but when we're newer and we don't, what might you have, how might you have found that information?
Well, I think I would have done exactly what you were just talking about with just arming my client with questions at that next ultrasound, or even giving her the option of having another appointment before the ultrasound and just having a conversation saying, I need more information around this, and maybe making an appointment with a different provider in that practice. So then she's able to get that second opinion.
I'm a big fan of a second opinion. And, I tell people all the time, I'm like, when you get any type of medical, like more like longer term medical care, right? Say you were going to have a surgery, or you were going to have, you would probably get a second opinion.
Absolutely.
If you were going to have surgery on your knee, right? We would, we would want to know, like, what are my options? What else do we think that we could do? And there's nothing, I think sometimes people have very similar feelings about their provider than they do about, like, their hairdresser. They're like, this person's seen my vagina, so I only want to go to them. I don't want any new people.
Yeah.
And I get that. But, sometimes that second opinion, and it can even help reinforce the decision that you make. And that's the other thing that I tell people. Like, this isn't necessarily to get you to change your mind, but then if you make that decision on, yes, I am going to get, say, those additional ultrasounds or whatever I'm going to decide to do, I know that, like, I've gotten this confirmed that this is an important thing to do on from more than one person, and I can feel really confident about doing that. You could get a second opinion that says, no, you don't need those additional ultrasounds, and you can still decide to get them.
Sure.
Totally within your right.
And then it is more confusing, though, because I have this one provider telling me one thing, another provider telling me the exact opposite. Who do I believe?
Yeah. What does your gut tell you?
What does your gut tell you? So let's go back with that brain that you mentioned earlier, because I think that's such a helpful formula for folks to understand, that they can utilize in that room. But we can also use it when we're talking to providers and staff as well.
I use it a lot.
I use it. Yes. Okay. So B, benefits. What are the benefits of making this decision? What are the benefits of choosing to use this tool? What are the benefits of what we're talking about?
Yeah. And I usually say that that one's the most obvious. That one's going to come out right away because your provider is trying to get you to do what they might genuinely think is best. You're going to hear it, whether you're the doula or you're the patient. You're going to hear what the benefits are. I think we should do this because.
Right. And that's like, okay, what's our best case scenario here?
Yeah.
Our best case scenario, we do this and we get this, and that's what we're trying to do. Okay. R. R is risks. Okay. So what are the risks involved here? What I also like to add on to this, because, risks, we can talk very medically about what side effects could come up, what could happen medically speaking if we choose this direction. How could baby respond? How could body physically respond? But something that I think a lot of people don't think about is the question that's kind of underneath that. If I'm saying yes to this, what else am I saying yes to?
Yes. What else does this entail? Are there any restrictions that come along with this? Does this, preclude me from getting XYZ type of care?
Right.
If I do this, will I still be able to get in the tub and labor that way? Or will I still have access to whatever, whatever it is I feel like I need?
Yep. And, with that, I had a client ask this question herself. She was just an amazing advocate for herself. So extremely proud of her and how she navigated the situation. But she was having a lot of contractions and she was getting prepped for a C-section. And they offered her, let me change that word because it wasn't an offer. They wanted to give her a shot of terbutaline to slow down the contractions so that she could get her medication, get nice and numb for the C-section without having all these contractions back to back. And she, even in that, had the wherewithal to say, what else can I expect from getting this shot? If I get this, what else am I saying yes to?
Good
basically. I know. And they said, well, you could feel some heart raciness, you could feel your heart rate quicken, but we're here, we'll tell you it's normal. You'll be safe, yada, yada. So she was like, okay, great. Decided to get it. And then after the fact, the baby nurse came in, so different provider came in and said, we need to check your baby's blood sugar. And she said, why? Usually babies who are, not giant, baby
Or not
was
super small, right?
not super small, are, baby was perfect range size, nothing significant, nothing remarkable. And she said, why the blood sugar test? And she said, oh, because you had terbutaline. And so you're at a higher risk, baby's at a higher risk of having low blood sugar. And so we need to do these tests. And so again, she had some other support in that room too. And the other support said, well, could you give us examples of what we'd be looking for in baby to show that baby has signs of low blood sugar without testing? Because baby has already been through a pretty traumatic experience, and we just had a C-section, and so what could we be looking for? And the nurse said, well, we're looking for tone and color and, lack of eating, really lethargic. And we're looking at this like bright pink, vigorously eating, nice, chunky, like perfect baby, just doing all of the things we're supposed to be doing. And so ultimately my client decided to forego the blood sugar pricks because it would have been, at 1 hour after birth and then again 8 hours later. And she didn't want to risk the separation. There was no concern over how baby was acting. And so she decided to forego it on her own. But that's where, even if sometimes we do ask, what am I saying yes to? What else am I saying yes to? We're not getting the full scope, which can be really difficult.
That can be really frustrating.
Yeah.
And I think as a doula too, because there are going to be so many things that we run into that we've never run into before, a medication, a complication, a pre-existing thing that particular person deals with that's a medication that's even outside of birth work, and I think that is also something for us to get really curious about and, be like, afterwards too, maybe talk to the nurse and say, hey, they had asked about the risks and they didn't hear that. Is that, now that I'm understanding that standard, is that something that, I can convey to my clients or like this, and now I'm going to remember to ask a little bit more about that. Can you tell me more about why that is? And that's how we learn stuff,
And that's how we learn stuff.
That's how we learn stuff.
Yeah.
For sure.
Asking questions.
Yeah.
Asking questions, having those hallway conversations, even reaching out via email after the fact to maybe someone in a different role. I have had plenty of experiences of having to go to the charge nurse or go to the director of a practice and say, can you please explain?
Yeah.
This is a situation I would like to learn. Is this how things are generally handled? Is this, out of the norm?
Yeah.
I would like to understand. And, it's not, what's the word I'm looking for? You're not telling on someone, you are holding people accountable. You are also trying to respect what everyone's roles are.
Right.
Right. And so the director of a practice, their role is to really make sure that practice is in sync with what the policies in the hospital are, what the protocol is, what their, what that specific practice, what their reputation is. Like, that's all really important. So, okay, we're digressing.
Now we're going to alternatives. RA.
Alternatives. So this is the options, right? This is where I think doulas really thrive.
Absolutely.
Because we get to practice in all the hospitals, the birth centers, the home births. We get to practice with CNMs, CPMs, OBs, nurses, everybody. And we get to tuck those little tricks and tips into our pockets, positions, words of wisdom, different tools, even different interventions that
absolutely
might be offered in different hospitals that aren't available in other places. So how have you handled bringing up options in a scenario like this?
Yeah. And are there any other options is just one of the first questions that I might. So we talking about X, is there anything else that would, be helpful in the scenarios that we haven't talked about yet? Or is there anything that, might help if I know what the other option is? Sometimes I don't, sometimes I genuinely am like, is this the only medicine we got? Like is there anything else and if it is, I won't know the difference, if I haven't run into the situation. But sometimes I know that there's something else out there. I'd be like, are there any other things that we can try? Is there anything else that, just so that we know that, we're picking the thing that feels right in this moment.
Yeah.
So just asking that. And then sometimes I might say, last month when I was in here, we did blank. And it was really helpful. Is there a reason why that wouldn't be appropriate? Would that be something that would be an option in this scenario? Maybe. I have to be humble, right? I have to be humble that I don't know everything all the time. So it might be that for my first client, it was appropriate due to their health, where they were in their labor, what the resources the hospital had available at the time, whatever. Right. And it's not appropriate in this situation for some reason that I don't fully understand. Right. So that helps me.
So let's get that out of the way first.
Right. Let's find out. Right. Yeah. Like, is there a reason why that might not, be appropriate in this situation? And sometimes the provider might be like, oh, I didn't even think about that. We could do that. There's really no reason we can't. And sometimes it'd be like, yeah, very specifically, here's why. And which good thing I didn't try to get all bossy about that because that wasn't appropriate in this situation.
Right. Yeah.
So, straight up asking, what else can we try?
And I think providers and nurses are more apt to listen in those moments when we ask questions like that. If we started off the relationship in that collaborative mode. Yeah. Working with a nurse, I always say L&D nurses are a different breed.
Yeah.
They came into this specific role because they genuinely love it. I mean, labor and delivery is different than ICU, a burn unit, the ER. This is an event. We are experiencing an event together. And yes, health is at the core and making sure that everyone is healthy and alive. And the nurse has their own responsibilities, charting and vitals.
They have a lot to do.
Documentation, reporting to the provider, administering medication, all of those things. But there's probably also a reason that they're doing this job because they like the hands-on. They like the, I had a L&D nurse in training once, and she had been an L&D nurse for 40 years.
That's amazing.
Oh, she was so incredible. And she was really like, I want everyone to know we love this job. We don't want to be pushed out of the way so that you guys get to do all of like the good feeling stuff, and that was such good insight for me. So ever since I, heard her say that, I've really upped my collaborative approach with nurses to in the very beginning say, what do you think about this?
Absolutely.
Do you have any ideas here? Have you ever tried this position? What feedback have you gotten? So now if you start off the birth with that collaborative approach and you're including her in making decisions and asking for input, then when it gets to the time that maybe a bigger decision needs to be made, you can actually have a conversation with your client and it feels like everyone's on the same page.
Absolutely. Do you know what my easiest in with establishing that with the nurses? Asking them. I use essential oils often in a diffuser during labor. I might put a little in the sink. I might put a little on a tissue. I might put a little diffuser. So when I meet them, hey, I'm so-and-so's doula. So nice to meet you. I think we've worked together before. Maybe we haven't. I don't know. I was going to set up a diffuser. do you have any allergies or do you have any sensitivities to any essential oils so I can know not to use them? Do you know that
Perfect.
almost always the nurse is like, oh my gosh, nobody has ever asked me that. Thank you. I don't,
Yeah.
but thank you so much.
Mhm.
Because they don't get seen often in so many different scenarios. And
Mhm.
they have to work in that space. And they work a 12-hour shift most of the time,
Yeah.
in many places. And so it's like, I don't want you to get a headache in the beginning of your shift that you have to carry with you. Like, I'm going to take
Mhm.
care of you. I'm going to try to be aware of you. And then we can work together. And it's
Mhm.
just an easy way of being like, hey, I see you. And I see that you have to work in this space and you have
Yeah.
to be in here too. And, always the nurse is like, oh my gosh, nobody's ever asked me that question before.
Yeah, you're
Easy
doulaing the nurse
peasy.
too. I love it.
Yeah, easy peasy. I've also had times where I've come in and be like, hey, I don't think we've worked together before. I love any ideas that you have. I welcome them and super excited to work with you.
Yeah.
Now, I've had a nurse respond with, well, you do the birth stuff, I'll do the medicine.
Great.
Cool. Now we've just established what we're doing today.
Okay.
That sounds awesome. You just bump up
Clear.
the pit and I will turn her over. Great. Cool. But like it just coming in and being like, I'm here to work together. It really
Yeah.
does make a difference
Yeah.
on that level.
Okay. All right. So that's alternatives. And then intuition.
That's the one that you can't know for them. And that's the
Yeah.
one, I always tell my clients, like, this is the one, this is only this.
Mhm.
And I also like to remind people that this has been informed by what you have absorbed over time, both good and bad,
Yep.
about birth, about your body, about, your baby, what feels right for you. And I trust you.
This is a tough one, I think, especially for first-time parents to tap into that
Yeah.
intuition. And that's where sometimes they can ask, well, what would you do? Or what did you do in this situation? And that gets real dicey
It does.
because you really, I assume that if someone has been put in that position before, they've done the research. They have asked the questions. I know when I was making decisions with my own birth experiences, my own babies, I researched the way that felt comfortable to me. My partner and I decided things that felt good to us with factors that we considered with our individual and unique life experiences.
Absolutely.
And so it's really important, I think, as doulas to understand that and to create a professional boundary there to not share what you personally did or would do because it's not your story. And so I think, especially in today's world where, there's even more questions being raised around vaccines and things like that with baby care and, newborn decisions, really being careful around making sure that your clients are making those choices with their research. Of course, you can give them articles and
Absolutely.
studies and
Yeah.
evidence and all of that, but it is their decision to make, not yours.
Yeah.
And I think too, I'll say things like, welcome to being a parent.
Yeah.
Like this shit's hard. It's really hard. Now you've got to filter through this stuff and like see what sticks.
Yeah.
See what sticks to your gut and what feels like this is the path you want to go down.
Yeah. And I've had 4 very different experiences with all of my kids. And so sometimes I'll say, I made different decisions in different situations just based on kind of where I was and how I was feeling. And, whatever you decide, will be the right decision
and I
for you in
support
this
that.
moment. Yeah.
I support what you decide, even if it is different from what I've decided. I think too, we talk a lot about the senses, the 5 senses in the training, and just we use those senses a lot in birth. But I always say there are 6, and the intuition is the 6th sense that we were all born with. And our senses are literally, we are meant to use them to navigate our life safely. And so using that gut work through pregnancy, birth, those early days with a newborn, that's It's so important because that's where the confidence is built.
Absolutely. I totally agree. And I've also said to clients, like, I'm not in your body.
Yeah.
I don't know, I don't know what you're feeling or what you're thinking. I'm not in there. And I'm not the parent of this baby.
Yeah.
So whatever, you do what you feel is right with your body.
Yep.
Which might be very correct, even though it was different from what was correct for my body.
Right. Saying that too, though, we also, as doulas, want to make sure they have all the information.
Right.
Because that decision should be an informed one.
Exactly.
So if they're just making a decision, based on, well, I've heard
Roll the
this one
dice.
thing and I guess I'm doing that, my provider said that's the thing and I'm going to do it. And so that's where we have the opportunity to say, would you like some more information on this? I'm happy to give you more information on this. Okay. And then the last one, N, is no. And that's really, what are the consequences of us declining your recommendation?
Yeah.
That's a tough one.
Or do we have time? So not right now. You can also take it with a not right now, right? Like, can you come back in 30 minutes, an hour? Can we talk about this after lunch? Now that we've had some time to now that we've just gotten this information, do we have time to can we just sort of let it sit for a minute, sort through our feelings about it? In which case I can, one might turn to their client and be like, do you want a little time to think about it?
Right.
Or do you?
And I'll always say, do you all want some space from me as well?
Yeah.
I can go grab some snacks for you guys. I can go, get coffee for the partner if you want some space. And, usually we're like, no, we want you to talk to us about
and
this.
I've had people who are like, we just want to make this decision, the two of us. And I'm like, awesome. That's great.
Great.
Because then too, whatever decision you came up with, that was you guys decided
Truly
that.
you.
And I feel good about that, And so it's like, this was absolutely, but most of the time it's like, no, you stay, everybody else go. And I'm like, okay. That's fine. Whatever they feel like they need. Not right now is powerful, and not right now is also a great way of handling pressure.
Yeah.
So, I always tell my clients, I'm like, if you are in a situation where you just need a little time, just tell everybody you got to go pee. Just go pee. Because we have that walk to the bathroom. Usually people kind of step out, step back. They've got other things to do.
They're not all going to come into the bathroom.
We're not all coming to the bathroom with you. You maybe just have one or two escorts. If you need to go pee, if you want a little more time, say you need to poop, just as long as you're not about to have that baby, go in there. Everybody will clear off. If you just need a few minutes, I know other doulas have said another great one is we need to pray about it, which usually kind of freaks everybody out in the room and then they go running. But you can ask directly for that time. You can encourage your clients, and this is a prenatal work too, that it's if we're in a place where you feel like you need more time, here are some things that we can do. Ideally, we're working with a provider because we've provided that prenatal support where we feel like they've made a choice of a provider that is going to have those conversations with them. But sometimes they're like, no, I'm sticking with this person, even though, that provider can be very challenging on certain issues.
Or maybe the provider that they did choose because they were in alignment on what they wanted is not on call.
Yeah.
And we have someone else
what happens
that we've never met before.
Yeah.
Yeah. Okay. I feel like we might need a part 2.
I think we do. Yeah. Yeah. Because I have a little tag on to that I feel like also really helps us navigate those types of things as doulas. So.
I think we've just sort of broken in just beneath the surface of being met with those challenges. But I would like to get more in depth.
Let's do it. Yeah.
Okay. So we'll do a part 2, but before we close out, do you have a doula experience to share with us for this episode?
Yeah, I do. Well, so there is a place where I work with a little bit more, a hospital that I work at a little bit more frequently than I used to. And they have it really depends on who's in, on kind of what some of the policies, and I say that in quotations because obviously if they were written policies, it would be a little bit different. And this specifically is with around doulas and triage.
Okay.
Now, I never have a problem getting into a C-section here. And I haven't actually been to many C-sections at this
I'm gonna
particular
knock on
place.
wood
We're
for
knocking
you,
on wood.
Sarah.
Yeah. But I do have a hard time sometimes getting into a triage room at this particular place because those triage rooms are a postage stamp size. And so
and it is the protocol, because I don't know that it's a written policy. I think it is protocol in this hospital that every patient does have to go through the triage room, which can be a little frustrating.
So frustrating.
Okay, go ahead. Sorry.
Yeah. So when clients go into this particular hospital, they have a cervical check and monitoring done in the triage room before they are officially admitted into the hospital itself. I always advise to my clients that the cervical check is in fact optional, though it is not ever presented in that way. But usually by the time people get to the hospital, they're ready to get that information.
Gather some information.
And then that 20 minutes of monitoring is also in this teeny tiny room. So the thing about this room is it's miserable. It sucks. It's just, and this is
not
triage.
a real
this
hospital
is not,
bed. It's a cot.
And this is just true of triage rooms. It is just the way it is. You have just done an awful ride that you had contractions on the ride on the way to the hospital. You are navigating the hospital for, possibly the first time.
Right.
You are not seeing always your provider. You don't necessarily know always who your provider is going to be when you come in. It's a teeny tiny room. It's not a real bed. It's a stretcher, and it's small and cramped, and you can't settle in, and all the big lights are on.
The nurse that's coming in might not even be the nurse that you
might not
are
even
assigned
be
to.
your nurse. So it is a hard place to labor. It is not built for labor. It is built for triage, and so it's inconsistent on whether or not I can get back there. And sometimes it's because a lot of times when they say I can't go, it's because the partner is already there, and the room is small and they don't need another support person.
Right.
Well, I had a wonderful client who had labored and so long and so hard at home, and really had a very long prodromal early labor phase. We had to do a lot of work. Once we did this work, boom, things clicked into place. She was rocking and rolling, and we were like moving. It was one of those situations where I'm like, I think now would be a great time to go to the hospital, trying to be like totally cool. But I'm like, we need to get in the car. And it really just flipped, like the labor just turned.
I love it.
So, and it was wonderful. And oh my gosh, I was so proud of her too. And prenatally, many times we had talked about, she had expressed to me that she does not want an epidural. This was not something that she wanted as part of her story. It was something she was working very hard not to have. And she had done 2 days of this very long labor. And we're,
so tough.
All of a sudden, boom, things have changed. So proud of her. She walks up like with this sheer determination. We were at that hospital. They let me in, no problem. We get into the teeny tiny triage room. She does a cervical check. She's 8 centimeters dilated. And she goes, oh, this is awful, because it's also awful to have contractions after a cervical check. Like those are so much stronger than they usually are before then. So she's in this teeny tiny room. She's cramped. Her pants are half up. She's got the monitors, right? She's like, is it too late for me to get an epidural? She's in transition.
Right.
In a crappy place.
In the I can't do this phase.
Yes. So I said, and this is what obviously angered the nurses, frustrated the nurse. I said, it is not too late to get an epidural, but we're not going to talk about that in this room. We're going to go to your room, get you settled, and then we're going to talk about it. Like, I cannot blame you for wanting an epidural right here, right now, because this place sucks. But we're going to move. And once we get in there, then that's where you would get your epidural anyway. So let's go ahead, get in, get settled.
Yep.
So we get her in the other room, and I say to the nurse, hey, I know we need to do blood work, but like, can we start filling that tub right now? And I said, she's really struggling. And she was, this is really tough, but I think, if we can get her in that tub, she's going to be really happy there.
Yeah.
And the nurse looked at me and she goes, I need to hear that from the patient, because I've only heard that from you. And I was like, I said, okay. So I turned to my client. I said, client, we have the option of getting in the tub now. Do you want us to go ahead and fill it? And thankfully she said yes.
Mhm.
I said, otherwise we could get fluid started for an epidural. And thankfully she said yes.
Mhm.
And we never got in the tub. She had a baby 45 minutes later.
But also we could get in the tub and we could get the fluids started, and maybe we'll just have a baby anyway before
Absolutely.
then.
So she has the baby 45 minutes later. She's amazing. I think the second words that came out of her mouth was she looked at me and she looked at really everybody in the room and she was like, "Oh my gosh, I can't believe I did it. I am so glad I didn't get the epidural. I've always wanted to do this without. My whole life I've wanted to do this without an epidural." Like, I don't know how long she was thinking about it, but like she was like, "I really wanted this.
Yeah.
And I'm so glad I didn't get it." And I was like, "Don't look at the nurse. Don't look at the nurse. Don't look at the nurse." And I was thinking about this triage situation that we run into here, because if I hadn't been able to get back into that room, that story would have been really different.
Yep.
And the story would have been, I've always wanted to do it without an epidural, but I couldn't.
Mm-hmm.
And it just, like, when I think about the triumph she had on her face, and I don't give a shit about whether or not my clients get an epidural.
Sure,
I really epidurals are great. Epidurals are not great. Whatever. I don't care. But for her, it was a really triumphant moment and something she really, really wanted. And if I hadn't been there, that story would have been different.
That time that she was being put into the room would, instead of doing whatever it is that you guys did while that tub was filling up and never used, that time would have been all about getting the meds. And she would have had to try to sit still, tried to wait for those fluids to go in, try to sit still for anesthesia. Who knows how long it would have taken to get anesthesia in the room. Ideally, it would have been quickly, but still it takes a good 45 minutes for the fluids, the anesthesiologist to get in there, to prep everything, to get the meds in. By that time, she would have had a baby.
And I would have still been in the waiting room. Because, they weren't going to go get me, there.
Yeah.
So, I mean, these little things that we feel like, they might seem like a little frustration, but they can really have a strong impact, on someone's experience. And so it is something that then when I, a little bit later, ran into an issue getting into triage, it was something I could speak to. Like,
That's
hey,
great.
if this had happened, when I came in with my client at 8, later I came in with a client at 10, if this had happened there, there would have really been a real gap in their care.
Well, there is.
Right.
And that's why we have jobs. Yeah.
So anyway, it was one of those, I'm so proud of her. It was just so happy, but the triumph on her face, when I think about the idea of somebody taking that from her, I was like, it was just a special moment. Yeah.
I love it. Thank you so much.
Thank you so much.
So now it means you have to come back.
Oh, drag me back.
Rats.
Absolutely. Anytime.
Okay. All right. So we will have a part 2 for how to navigate the challenges when dealing with providers and staff and just different expectations, really, of hospital systems and such. And this can even go birth centers and home birth too.
Absolutely.
So it's everywhere. We'll figure out a better way to describe this. Thank you so much for listening. We do have a doula training coming up in January 23rd to the 25th. We've got a just stacked calendar of workshops for 2026. So please go to the website, tolabor.com, and check those out. We love to hear from you. So please send feedback, questions, comments. Do you want to be a guest? You want to come on here and we can talk birth? Please email me at melanie@tolabor.com. Please follow us on Instagram and Facebook, ToLabor, and
leave a review.
Follow us, subscribe, leave a review.
Do all the things.
All the things, please. And thanks for listening. This episode was recorded at Vera House, produced by Perry Young and Mike Metzger, and special thanks to my husband, Jared Russell, for his lighting tweaks and input all along the way.